Hi guys, it's Dr. Doty. We're going to get into some of the heart health stuff that the education we're doing this month. But the first thing I really want to take a look at is a lot of the stuff around cholesterol and what the real truth is behind that. So this video, this quick little presentation is kind of going to dive into some of the blood work numbers that medical doctors tend to tell you are important when it comes to knowing your risk of heart health. Now, a lot of the old ideas are around LDL, and we're going to dive into that more in depth here. But we need to find out what we really should be looking at. So let's look at what the true markers for health and wellness or health of your heart really is. Let's start with some of the basics. The basic units when we're dealing with blood work is milligrams per deciliter here in the United States. In Europe, they use millimoles per liter. Just if you see those differences when they look at cholesterol, that's all that means. And there's a conversion between the two. So that's a very basic idea of what the units are for the cholesterol. So the director of the Framingham study, which was one of the biggest studies that looked at heart health that we've done, talked about LDL. And he quoted after doing this study and looking at the actual data that unless LDL was really, really high, and he quoted over 300 milligrams per deciliter, really in isolation, looking at your LDLs had really no bearing on whether you were more at risk of having any kind of heart disease. He also stated that the ratio of the total cholesterol over HDL cholesterol was a much, much better predictor of future cardiac events than any of the individual cholesterol numbers, as far as what they found. But this wasn't just in his study. This was also in the Physicians Health study, and other studies have now shown this as well, that this ratio of total cholesterol over HDL is actually a much better predictor of your risk. Now, here are some cholesterol ratios that we're going to be looking at. And so I want to kind of give you an idea of what they are, what the clinical numbers are saying, and what actually maybe a healthier goal or target. So if you look at the total cholesterol over HDL, clinical is anything under 4. So 4.5 or under. What we look for as far as more of a healthy target is under 4. So it's just a little bit more of a narrower window for that ratio. And then there's triglycerides over HDLs. That ratio, ideally clinically, you would be under 2. Healthy, we're looking to be under 1.2. So anything under 1.2 would be more of the healthy range for these cholesterol numbers. Now, let's dive into some research here just to kind of show you what, they found as far as the LDL cholesterol numbers. So this is a study that looks at lipid panels as a marker of insulin resistance, which would determine future cardiovascular disease. So we have a couple groups here. So the first group, they followed, in fact, this, as you can see, it was a big study. There's over 100,000 members that were in this study, both men and women. And we looked at these two numbers of your LDL-C, your total LDL cholesterol numbers. If it was greater or less than or equal to 140, there was a 13% rate of possible cardiac events, in the future. If the LDL-C was greater than 140, that only went up to 14%. When you looked at the ratio, if you had a low triglyceride to HDL ratio, you had about a 9.2% greater risk of having some kind of heart disease. But if you had a high triglyceride HDL ratio, you had an 18.5% increase in risk of our rate of cardiovascular disease. Why is that? Why was this so low and this so high? Well, what they found was the group that had the lower triglyceride to HDL number had less insulin resistance. And we know that insulin resistance causes inflammation, which is one of the major markers of what actually truly causes heart disease or cardiovascular heart disease. This group that had the higher triglyceride HDL had more insulin resistance. Basically what this means is that it's just looking at the blood sugar and how you're handling blood sugar in your body. So obviously you want a low ratio and also a low insulin resistance. And that's what is actually a better predictor of future heart events. Now, another study that talked about the efficacy of cholesterol levels and ratios of predicting future coronary heart disease. The big idea with this is that they have two groups. And once again, they looked at the LDL, the lower LDL and the higher LDL in group A, and there wasn't much of a difference. And then the same thing in group B. But in group B, the interesting thing was the lower LDL-C number was actually had a higher risk of future cardiovascular events. So again, why is that? Why is there really not much of a difference in group A? And then there's a major difference specifically in the lower side of the LDL numbers in group B. Well, what this research showed was in group A, the total cholesterol HDL ratio was low, meaning that was a good number. So it didn't matter what the LDL number was. With this ratio, basically the risk factor was about the same. When you're looking at the total cholesterol HDL ratio in this group B, it was very, very high. So that gave them more. Once again, we talked about the insulin resistance. This is the same concept. The body had more inflammation because of this high ratio. Both of these numbers are significantly higher than the lower ratio, but the low LDL is something that they even had a greater chance or greater risk of some kind of cardiovascular event down the road in the future. Now, my question is, oftentimes, why do medical doctors prescribe statins? To lower cholesterol, right? Specifically, which cholesterol? LDL cholesterol. But as you can see here, LDL is a very poor predictor of actually whether you're going to have a cardiac event or not. So are statins really reducing your chances to have heart disease or strokes? That's debatable. And you can see that from research, it's not a very good predictor. The number that they're trying to lower is not a good predictor of future cardiac events. And now we're seeing more and more of that research coming out. Now, here's the one thing I want you to understand. There's a difference between the LDL-C, which is the concentration, all of the low density lipoproteins, and the LDL-P, which is the particle size of these low dense lipoproteins. There's a big difference. And the reason we need to know this is because of the following. When you have the same number of LDL-C, so let's say 130 milligrams per deciliter, which would be considered high, then they probably put you on a statin for this. The size of the particle, the LDL-P, the bigger, fluffier particles you're gonna have a lower risk of having any kind of future event, and that's what they call a large LDL pattern A, like the pattern A. So they're large particle size. Now, the small LDL, which is pattern B, sometimes is called ApoB, these have a higher risk of causing damage in the endothelial lining of the arteries, which would cause a higher risk of having future events. So it's interesting that even though you have the same LDL concentration, depending on what size the particles are, can make a big difference in your future risk. Let's talk a little bit about why that matters. So these are the layers of factors that cause damage in the arteries themselves. So first of all, you have the red blood cell, and then you have these oxidized LDLs. Now, what that means is the oxidized LDLs are damaged LDLs. Those are the small particles of the LDLs that have been damaged by oxidation. Now, what happens with that is as it starts to move through what's called the glycocalyx, which are these basically ways of filtering out what's going on just above the epithelial layer of cells. These glycocalyx can help filter out some of these oxidized LDLs so they don't get down into the cellular level to cause more damage. And then the last layer of the cellular portion is called proteoglycans. And those are another layer of protection before it really starts to cause damage. And the other aspect of this layer factor is HDLs. Now, you've heard HDLs are good cholesterol. What they do is they are basically cholesterols that can take these oxidized LDLs and have them recycled so they don't cause as much damage in the cell. So they basically go in and kind of pick up old, bad, damaged lipoproteins, especially these low dense lipoproteins, and they take them out. So that makes a big difference in your chance of having a heart attack. That's why doctors are so focused on getting your HDL numbers up. Now, it doesn't make them, let's say, good. It just helps. It's a positive overall net benefit if these HDL particles are working well. And it doesn't necessarily mean LDL particles are bad. We have this good-bad relationship with these two particles, and it really isn't necessarily that. It's just the fact that if your body can handle and not cause the inflammation, which is truly causing the damage, that's going to be the biggest predictor of you having much better heart health down the road. So, for example, we have two individuals here, one that's having, issues with heart stuff. What happens is all of these LDL particles, and you're going to have some that are oxidized, are going to start kind of working their way through the artery, which we just showed you, the basically the cellular lining of the artery. And if those glycocalyx can't filter out some of those LDLs, you're still going to have quite a bit of the LDLs going through down to the epithelial lining. And then through that, it goes to the proteoglycans, which are also supposed to pull those out. And also, if this person's or HDL numbers are lower and they're not able to process out some of these bad LDLs, these oxidized LDLs, that's when damage happens. That's when you actually start getting the plaque that you hear about that builds up on the interior of the lining of the arteries. Now, this person, same situation, has the same LDLs, but because of factors that this person is doing, has less inflammatory markers, has less oxidated or damaged LDL, but some will still get through and could possibly cause damage. But less is going to get through because these are bigger particles, they're less oxidized, they're not having a big issue, even though they're all LDLs as well. So there's those filter through to the end, and then that person's good HDL numbers, what ends up happening is these HDLs are not causing any damage. So they're fine. They're good. They're just a normal, LDL number because they're being processed through the system properly. So here's the markers you really should know. So this first marker, the F2 isopropostans, it's basically one of those first inflammatory markers, that and oxidized LDL we just talked about. So these two are early in a heart disease process. Are you having inflammation that could be leading to oxidizing these low density lipoproteins? So these are the two numbers or markers that you would want to look at blood work wise. Then the next level would be looking at systemic inflammation. And that's what this high sensitivity C-reactive protein does. So this is looking at systemic inflammation across the entire body. If that goes up, then the higher that number is, the higher the chance of you having some kind of heart event, because you're basically creating, most likely through some insulin resistance, which we could talk about in a different video. But this higher inflammation is going to cause more damage in the arterial walls. Then this LPA2, the plaque test is what they basically call it, is actually looking to see, are you starting to build up some of that damage on the cell walls and what's happening with that. So if this starts to go up, you're going to know that you have some heart disease progressing already. And then one that's going to show up if you really are starting to have damage deeper into the actual lower layers, where not only do you have the plaques, but they're actually cracking and they're causing more damage, which leads up to a heart event. This MPO test is going to give you a really good idea of that, if that's happening. And this is more in the late stages of heart disease. As this goes up, your risk for heart attacks will definitely go up significantly. And another really great way to find out where are you as far as heart health is a coronary calcium scan. So basically what they do is they scan the carotid or the coronary arteries and look at the calcium that's lining that. Obviously, the lower the number, if you are below 10, if you're a 0, your chances of having major cardiac event in the next several, up to 10 years is pretty low. As that number starts to creep up, your risk goes up significantly. So these are the markers that you really should know. outside of cholesterol numbers, that's going to let you know if you're at risk of a heart attack. So hopefully that gave you a little bit of a different look at what cholesterol means. I think a lot of you, have probably heard about statins and like why doctors are prescribing them. It's usually due to high cholesterol. But maybe we should be looking at some other things. Maybe we should be looking at sugar handling, inflammation, because those are the real true culprits to what's causing heart disease, much more than the cholesterol numbers that most medical doctors are concerned about. If you have any questions about that, please don't hesitate to email or to talk to me here at the clinic. But I hope this made some sense, and I hope you got some good information out of it. Have a great day.